continue to irritate all of us for the next few minutes, I guess. I don't think there's any way of turning it off. But welcome to all of you, and it's lovely to see quite so many people. So my name is Richard Davenport. I'm a neurologist in Edinburgh. I'm the least important person on the bill today, so you can forget that. What is important is the subject, which is FND, and the size of the audience alone highlights how much appetite and interest there is in this subject. We know that it's a big problem in terms of numbers. We know it's a big problem in terms of distress for patients and their families. And I think if many of us are honest, and I will certainly be very, very honest here, I think from our side of the table, we often find people with FND quite challenging to manage. And certainly after 26 years as a consultant, I still find them amongst some of the most challenging patients to help and manage. So it's a real pleasure that we have a suite of esteemed experts to take us through it today. Esteemed or not, I have to remind all our experts that we're on a tight schedule, so keeping to time is very important. We want to have 15 minutes of Q&A at the end. And on that note, Pete, please feel free to put questions into the chat as you go. I'm not sure we can put hands up with an audience of several hundred. So please pop your questions into the chat and we'll be monitoring that. So to kick off, we've got my colleagues from NHS Lothian, Professor Jon Stone and Michael McLean. Jon is a friend and colleague, so I am biased, but I think most of us recognise that he's done more than most people to drag FND kicking and screaming into the 21st century, although it's been around, as he'll tell you, for a very long time. So Jon and Michael, if I can invite you to start this session, thank you very much.
Thanks very much, Richard. So hopefully you can see my slides there. So I'm a neurologist here in Edinburgh, and the purpose of today's session with the 4 talks you're going to hear is really about service innovation. So we don't have time for a sort of deep dive into FND, how it's diagnosed and managed, but I'm hoping a lot of the audience already have a fair understanding of FND. There will be resources and links going along. We're talking for 10 minutes here about particularly our FND specialist practitioner pilot scheme that we've been running and lessons we've learned from that, sharing that experience. I'm going to talk for about 2/3 of it. And you're also going to hear from Michael, who's one of our FND specialist practitioners, sharing that single post. So FND, a common condition, one of the commonest in neurological practice. It's pretty hard to know exactly how many people have it, but I would at least around 10,000, probably more. I think most estimates are probably underestimates, depending how you define it. We're talking here about patients with neurological symptoms like paralysis, tremor, seizures, inability to speak, and probably as well symptoms such as very persistent dizziness, a condition called triple PD, and functional cognitive disorders. What FND doesn't describe is chronic pain, fatigue, because those have separate services, etc. But pain and fatigue overlap very strongly with FND. Probably around half of patients with FND also have chronic pain. And things have changed a lot from when we started our interest in this over 25 years ago. We now have pathways and guidelines in NHS England. I'm going to tell you a bit more about the Scotland one. It appears now as a central condition in training curricula for neurologists in the UK and Europe. And recently, NHS England made FND one of their 7 core services that each regional neuroscience service should have. So it's fantastic to see it is sort of entering the mainstream, having been very hidden and neglected for a long time. So the Scottish pathway, that was one of the reasons for having this session, was to highlight the work that was done by many of the people on this call on this FND national pathway from the Centre for Sustainable Delivery. You can find it on the internet. These were some of the key components: making a positive diagnosis by people who had the expertise to do so, having a core network team responsible for FND, typically in a regional neuroscience centre, but then also thinking about the wider network of other health professionals pain services, mental health services, primary care. Everyone has to get involved, really, because this is not a problem that you can just have in one service, if you like. And one of our recommendations for implementation of this pathway was access to an FND specialist practitioner, a role that only exists in 2 other places, I think, in the UK and probably the world, Bristol and London, and they've just started as well. So we're all sort of learning about whether trying this out, is this a good idea? What benefits could it bring? It's just one component of an FND service. And it's important to say that when I'm talking today, not suggesting the FND specialist practitioners are sort of the solution to the whole service, but I think they could be a really important component. So this is an idea of the pathway here. So we've got the person with FND in the middle. We've got the FND core network in the regional neuroscience centre, neurologists, neuropsychiatrists, psychologists, etc. And they will often be most involved with the patient with FND, but of course primary care, secondary care, particularly A&E, and be thinking about treatment arising from that core network. But then there's also a wider network of people also seeing these patients coming in at different entry points. Some of those patients improving, some even recovering, because that does happen, but some not improving and having persistent disability. So that was a very sort of rough sketch of the pathway. There's a lot of people and moving parts here. In Lothian, this is just to give you an idea of some of the mapping we've done in Lothian. You've got the core network there in blue, and you've got all of these other places where people with FND turn up. And our team have been asked to talk at the prison, by the university GP practice. Just shows children's services, just shows you how many different places you have to think about when it comes to FND. Incidentally, we have our own FND Ref Help page there for GPs, which describes our service if you wanted to see that in more detail. So our FND specialist practitioner pilot was initially got funding from Scottish Government, who are co-hosting this event. Thank you very much, Scottish Government. I've been trying for 10 years to try and get this post, so it was great to finally get it kick-started. That was for 1 year. We've recently got NHS Lothian charity funding for another year, and we're trying desperately to get permanent NHS funding. Very challenging in the current climate. Applied for a single Band 7 post. It was downgraded to Band 6. We've applied for it to be upgraded again because we think it is a Band 7 post. It's one 36-hour post, but I managed to get these 3 superb and very experienced colleagues to share it. And I'm definitely getting value for money by having the 3 of them. As you can see, Laura and Sarah there, 2 neurophysios, very experienced in FND, and Michael with over 10 years of experience as a senior neuro nurse as well. Incredibly useful to have the combined backgrounds. So this is how we sort of launched the post last year. Said, look, here we are. Now it's only 1 post, so we've got to be careful about what we're offering. And what we decided to offer was an inpatient acute service to support patients in acute settings, to help them get discharged home a bit faster, to help them when they're having crises and relapses, and also to spend at least a third of the post doing teaching and building up a network. And I think that was the right decision with hindsight. It was partly governed by thinking about how we might persuade people to carry on funding. So at the moment, they are not seeing just outpatients. It's not the same as a sort of epilepsy nurse specialist, for example, seeing everyone with epilepsy as an outpatient. And we've got to be careful about not straying outside our lane in terms of under 16s or patients where the dominant issue is mental health. So I'm going to hand over to Michael now, and I'm going to run the slides for you, Michael, just to take us through some of our data.
Just to make sure everyone can hear me all right? Right.
Yes, I can.
That's fine. Perfect. So I'll very quickly, I know we've got less than a minute, we've got negative time at the moment, so be as quick as I can, but the first bit of data there is just looking at the number of patients who've been referred, so that's in about 11 months of being active. So 144 in total. It seems to be, it's growing over time. We now settle in about 15 to 20 a month or so, but the numbers are getting bigger, and we're having to be more more strict with our already quite strict criteria. We're about half are in outpatients, so that's like trying to prevent people coming into hospital, supporting them in the community kind of thing. But a quarter are in acute services, so A&E and AMU, and another quarter roughly are in DCN. Our DCN patients are probably the most intense in terms of, like, we were very present on the ward, broadly speaking, but so it's a big group of people there. Second bit of information there, so that was looking at some data we looked at. So we looked at 6 months of patients looked after by Jon and Ingrid Huritzauer, who's the two specialists in the department. So any patients under those with FND in the Department of Clinical Neurosciences for 6 months when we were present, and then the same time the previous year. We were comparing the number of admissions, the length of stay, the average length of stay, and the total bed days. And the impact was quite profound in terms of the admissions were halved, the length of stay was halved, and we dropped the overall bed occupancy by about 80%, which is pretty significant. Obviously, you have to take a massive pinch of salt. This is very preliminary data. But we did look at another 6-month period to compare it, and it was quite similar, so it's not a complete outlier. We're now about 5 days away from having an entire year's worth of data, so we'll go back and we'll have a proper look at all of the consultants and see if that is something across the board. That will probably flatten the curve a little bit, but we're pretty confident that we've had a pretty significant improvement on and discharges in DCN at least. We've got the preventing admissions there, 70 admissions prevented. That is an educated guess. It's very difficult to investigate and prove that sort of thing, but we're just looking at the number of patients that we've had interactions with as an outpatient in A&E to try and prevent them coming into the front door. We've been quite successful on that. And frequent flyers, we haven't got data on that yet. As I say, we're almost a year in post, so we're hoping to look at our most regular attenders to A&E and DCN to see if our input, we've been directly involved in them, and see if our input has had much of an effect there. As Don was saying, we have had a lot of training. We've done, essentially we've said yes to everyone who's asked, which is a pretty bewildering number of specialities there. We've had, it's now well over 30 sessions and well over 1,000 health professionals we've trained. The impact we've had is, I think, fairly significant. Certainly, like, we've felt it in DCN at least, that the attitudes have shifted a little bit more towards being positive and a bit more understanding, and we feel a bit better about our colleagues at the front door knowing they have us to rely on and just having a bit more of an understanding. And was there one more? And we've had some feedback from patients and from staff, so I'll just read this one out. I've had FND for a long time, and this is the most supportive I've felt. My GP doesn't understand FND at all, which is a very common complaint. It's good to have someone contactable who understands. I've never had a relapse plan before. It means I should be able to manage my relapses myself in the future better, rather than having to come into hospital. Which kind of summarizes our main goal is to try and support people whilst they're in hospital, to give them tools and skills and a contact so they don't have to come back in. And this is a game changer. I really hope the funding stays in place because it's been so amazing for me. So that was a patient who's been to A&E quite a few times, and she has almost uniformly a really horrible experience. Her and a few others have gotten to, our frequent attenders have gotten to the habit of contacting us directly so we can see them in A&E and either just bounce them straight back out with support or make sure they get to an appropriate ward. And this is from one of the acute medicine AMPs. The FND specialists are crucial in driving the service forward for this patient group, and they have an immediate and direct impact on patient care. We are very popular in A&E and AMU. These patients are often very complex, as has been noted, very hard to manage. We have the expertise and, quite crucially, the time to sit with them and unpack everything, and then advise what to do further and support the teams and how to safely manage and discharge the patient. And we have recently been shortlisted in 2 awards. So one was for the, Respect one, which is about supporting patients with disenfranchised patients. And the other one was for innovation. We didn't win either of them, but that's kind of reassuring because we're very new in post, so it was a bit overwhelming. But it was very gratifying to be highlighted for those, and my 2 much more competent colleagues were able to go to one of the events and had the free wine. I was working, sadly, so I didn't make it. So I'll pass back on to Jon, I think.
Thanks, Michael. In fact, we're only 1 minute over, so okay. But
okay.
So So to summarise, I think there's been a very positive development for a single Band 6 post. I think this is incredible value. We are very likely saving the NHS huge amounts of money, as well as providing better care for patients, making staff more confident, improving morale around this problem. We would obviously like to do more, collect more data, have more time, do more outpatients, but we think there's a great opportunity here to improve FND networking, Scotland, etc., create resources, paper training. So I'll stop there. Thank you very much indeed.
Jon, Michael, thank you very much for an excellent setting of the scene. Just a reminder to the audience, we're going to take questions at the end, but please put them into the chat. So we're not ignoring your questions. I'm keeping a careful eye on those, and we'll come back to those questions in the last 15 minutes. Right, so we're going to move slightly to upwards and to the left to NHS Forth Valley. Pete Connick is a consultant neurologist colleague there and lead for the FND service. Pete, welcome.
Thank you very much, Richard. Hopefully everyone can hear me, and I shall share my slides. There we are. Right, so good afternoon, everyone. Thank you for the opportunity to share the experience here in Forth Valley of our FND service. Yes?
Pete, sorry to interrupt. Sorry, can you put it on slideshow? Sorry,
yes,
it's just in the slide sorter. Sorry, beg pardon.
Oh, apologies. Let me see. So it is should be on now. I will stop sharing and try that again, Richard. Apologies. Let's try that afresh. Slideshow. How about that?
That's better. Perfect.
That's better. Excellent. So, good afternoon, everyone. A chance to see the perspective from, as Richard says, slightly further north. So, let us move on. I joined NHS Forth Valley in August 2020. What a time to join an organisation. And at that point, we had just completed a review of our service provision. We didn't have a clinical lead for FND at that time, and we didn't really have an FND service. So I thought, well, that's an exciting challenge, and decided to put my hand up, take that one on. There I was, newly minted Vice Admiral of the Swiss Navy. No port, no boats, time to build. And so that's where we got started, as doctors do, started running clinics. That's continued since. Pretty early on, we managed to get our wider network together, and we've been running monthly MDT meetings. So we've got neurology, myself, psychiatry, psychology. Early on, we had a GP join us to develop some of the local pathways, as well as all of the allied professions from physios, OTs, nutrition, speech and language, etc. What really made the difference, I think, locally, of course, it's always a bit grandiose to call oneself a service if all one is doing is a clinic and talking to people, is when one of my colleagues from the epilepsy nurse specialist team decided to join the FND service. Now, that was very organic, and that's been the story of how we've progressed in Forth Valley. As you might know, about 15% of people with epilepsy also have dissociative seizures. And so one of the common complaints we had from the epilepsy service is, what do we do with that patient group? And so I was really happy to have one of my epilepsy nurses join and start to build a service for people initially with dissociative seizures, and then from that branch more into more general FND presentations. And that package has continued. That's mainly been in contrast to what you've heard in Lothian for an outpatient population, and we've gradually moved towards doing more in-reach work over time. But what Darren's been providing has been an addition to the psychoeducational piece, also developing some early psychotherapeutic interventions as well. So initially around meditation-based techniques, and then moving into becoming a qualified hypnotherapist and bringing that to bear as well. So having grown very organically, we decided at the start of calendar year 25, we should probably find out if what we're doing is actually making any difference. And so we audited years 23, 24. And I'm happy to say that the data is very encouraging. So over that time, just under 60 patients came through that clinic, some of which would have gone on to the nurse service, some on to other destinations, more of which in a moment. And the good news, very similar to Lothian, is that that certainly seems to be a cost-effective thing to do. Looking at the 12 months before they come into the FND service versus the 12 months after, very substantial reductions in their emergency department attendances and their hospital bed days. That's where the big savings are, but equally savings in all the other outpatient activities and diagnostic imaging. So that's exciting, and that certainly made my management team happy that we were doing something that was at least cost effective. What made me happy was to see that actually the patients got a bit better. So working with Darren through that specialist nurse package, we saw reductions in all the key metrics. So reductions in distress, that's a big part of this, improvements in some of the mental health metrics, but crucially improvements in dissociation and the neurological features. So a worthwhile venture, excellent. We've cured FND in Forth Valley. Well, unfortunately not. We see this as being necessary, but only a part of the story. And what we find is that if we do this for the right patients, that's effective, but not sustained over the long haul. When we see patients 12 months later, often they've started to slip back. So that raises a bunch of difficult questions in FND that one has to face, such as, well, why? Why are they returning to this state that we had thought we had fixed? And these are questions that we often struggle with in that particular set of patients. But turning to them, we thought, well, they're not new questions. I mean, clever but annoying 2-year-olds have been asking why questions since time immemorial. So clever and equally annoying Greeks have thought carefully about how you answer why questions. So in terms of how we think about FND and how that guided us in terms of our pathways locally, to be as pretentious as possible, if we work through the Aristotelian taxonomy of why questions, why do they have it from a material sense? Well, they have a problem with brain function. Well, the clue's in the name. What's the formal cause? We accept the computational neuroscience model of that this is a maladaptive state of network weights, and we accept the Perez summary of all the imaging data that's mainly in limbic salience, but other relevant brain circuitry. A lot of neurobabble there. Why has this happened? What's the thing that drives it? Well, this is, as John Vervaeke might say, agent arena adaptation. In other words, this is an agent adapting to their environment. And what's the ultimate cause? Why is that adaptive? Well, of course, we think of these as dissociative disorders. So this is a solution to a problem. In other words, this is an escape from a body, an environment, or an identity that it would be too painful to remain in. And using that lens, that then lets us start to think about the kinds of patients we see in terms of clusters of how they have ended up with FND, and then think a bit more rationally about what pathways we can offer them and how to manage them better. So on the right-hand side, we see 3 big clusters of the kind of people who get sent to the FND service. We've got young adults, often with a history of chronic trauma. They may have a formal diagnosis of chronic or complex PTSD, other aspects including personality disorders, etc. Often there's an acute trigger and then quite a rapid blossoming phenotype, lots of dissociation, and these are the most amenable to treatment. These are the patients who often have an awful experience, but actually we do the best work in, I would say. There's another cluster we see, the midlife adults who have very little in the way of prior trauma, but also little in the way of background mood disorder. These are in essence our boiled frogs, people who have got burnout, not a medical condition. It's so difficult to manage in medicine. And often they have something that triggers it that can be an adjustment disorder to a major life event. But then what happens is lots of iatrogenic feedback. Doctors don't know what to do with these people, and they keep sending them to other doctors with lots of normal tests. They're tough. And then third, we see another group which are quite different really, with a neurodivergent background, often moderate autism spectrum disorder, where a very minor physical illness is often the trigger. So these are our patients who develop a sore throat, stop swallowing, and then never swallow again. Extremely challenging to treat. So what do we do with these people? Well, the ones we've had the most success with are that first group, are young adults with a history of trauma. And in essence, how we see it is we use Judith Herman's 3-stage model of therapy for that. The neurology component of this is really delivering that stage 1, giving safety and stabilisation, the first chance they've had to build a relationship and feel secure. And that often results in that initial improvement. Then the problem is, where next? How do we sustain that? How do we get them into something that's more like a traditional trauma therapy, where you've got to turn and face what has happened and then integrate and heal from that? Is that via NHS psychology, or does that have to be elsewhere? Well, we have the same problem, as I suspect we all do across this call, in that FND is common. As Jon mentioned, at least 10,000, maybe as much as 12, same prevalence probably as MS across the country. And how many NHS psychology staff are in post? About 1,700. There isn't really a prospect of that. I happen to think there was an excellent plan for how we might diffuse trauma training throughout our workforce, particularly to people who'd be facing it, that 2019 plan, but of course COVID happened and that plan fell away. It was somewhat overwhelmed, so perhaps a case for revisiting that. But given that psychology struggles to see these people within 18 months, we've turned to alternative pathways locally. So with that group of young adults with a history of trauma, we work quite closely with third sector organisations here in Forth Valley. So Scots Recovery from Childhood Abuse, which I'm a trustee for. I was doing some training with the counsellors on FND at the weekend. HStar Scotland, another partner, and we've had excellent results going through that path. This is a big chunk of our FND patients, and that has worked well. What do we do with the burnt out midlife adults? Well, interestingly, they often don't want an NHS model. They're not particularly interested in that. They do well with self-funded therapy because actually they prefer more of a positive psychology approach or even a life coaching approach. Sometimes somatic therapies work well for them. So that often is the way for the NHS to then say, actually, this looks like a positive way forward for you. We can be uncomfortable about referring to private sector, but in my experience, they've done better there. As for what to do with our patients with neurodivergence, particularly autism, who develop FND, the truth is I don't know. These are very challenging to treat. On my to-do list is to go and talk to Scottish Autism about this. Founded in Alloa after all, so my patch. With my liaison psychiatry team, we think about, well, are there any cutting edge possibilities for doing research? Things like ketamine assisted psychotherapy. There's a biology and a plausible argument for doing things like that. If anyone's planning research in that space, come and talk to me. I'd be very interested. So to summarise, hopefully in time, we've grown organically here in Forth Valley over the past 5 years, but I think we have actually converged on the kind of model that you've heard about in John and Michael's talk just now. In neurology, we've developed a lead clinician, and the specialist practitioner service happens to be a nurse, but it needn't be. That's been clinically and cost effective. We do psychoeducation there, but also some basic psychotherapeutic intervention, and that achieves stability, really. Then we have pathways for what follows on for that. And I think mapping that out nationally is probably helpful, just to say that that's an approach that has merit. Accessing further management does remain a challenge. We use a mixed model across private sector, NHS psychology, and also the third sector. I do think there'd be merit in looking again at the psychological trauma training plan. And given time, I think I'll stop there. Thank you very much.
Pete, thanks very much indeed. Now, just in the last minute, whilst we've been listening to Pete, we've clicked over just onto 300. It's just dropped out to 299, but we did hit 300 briefly, which is the biggest meeting I've ever been to, which is amazing. So thank you all for joining. Right, we're going to move on. We're going to go shoot straight down the M8 and arrive in Glasgow. Sharon Mulhern and Saif Razvi, clinical psychology and neurology, respectively. I'm going to focus a little bit more on dissociative seizures. So Sharon, Saif, welcome.
Hi there, thank you very much for having us. Are you able to share our slides? Because I'm having a problem sharing them my end, if that's okay, thanks.
Yeah,
so
up, Sharon.
Sorry?
They're on the screen.
Oh, are they? Great, thank you very much. What's that? There? No, I don't even know control. Okay, thank you. So Saif and I are here to talk. I'm going to do most of the talking, but Saif's here to answer any questions as well. So we're going to speak to you about the educational app for people with dissociative seizures, which we developed here in Glasgow, thanks to funding from the Scottish Government. Next slide, please. I think you guys are going to have to move the slides on for me. Thank you. So the aims of our app that we decided to develop was really to ensure that there was high quality patient-centred information in a central point. We also wanted to try and tackle the demystification of the illness, as we know that there are lots of different sort of theories and understandings of dissociative seizures. Importantly, we wanted to have easy access and make it really nationally available or even globally available for patients, and free, obviously. And we wanted to ensure that it allowed patients to access this information in a timely manner that was suitable for them, because as we know clinically that people come to this diagnosis and understanding of the diagnosis and management of the diagnosis at different time points. So having the app available for them to use in their own time frame we thought was important. We wanted to ensure the education within the app was suitable for patients, for carers, and for health and social care professionals as well. And ultimately what we hoped as an educational app is that we would all be able to help provide support for patients and their families to live well with dissociative seizures. Next slide, please. So the kind of information that we pulled together, and we did this through focus groups, which I'll show in the next slide, is to say what exactly are dissociative seizures, to think about who they affect and why they happen. Importantly, to understand how the diagnosis is made and move away from this idea of diagnosis of exclusion and not understanding. Look for common clinical features that is seen in this population, and importantly, how to get better, how to self-manage and really being much more a director of your own care. So things like goal setting, managing expectations, and different self-management psychological techniques and strategies that the patients and their families can engage with in order to improve and live well with this condition. Next slide, please. So we decided to go down the route of having an app, because there is a high digital literacy within the population. There are increasing use of apps and websites, as we know, on a daily basis. The importance of an app is that it's convenient and it's accessible at any point, 24/7, and anywhere that you are, as long as you can have Wi-Fi. It's free, as we've said, and you can go at it, as I've said previously, about in your own personal space and time, and at a pace that really is relevant for you. It allowed us to link into other lots of information that's already out there within NHS websites, third sector websites, etc. So it allowed us to utilise without reinventing the wheel. And we think there is a potential to continue to develop that and incorporate further tools. Next slide, please. So what we did is we went to the Scottish Government. Saif and I applied for a grant in April and was awarded this in April 2021. We set up a working group just to sit down and think what would be their best approach in order to develop the app. I think really importantly for us, we linked in very early on with our library services, who were absolutely invaluable in making the appropriate links for us and guiding us in how to develop the app, and thinking about where that this could be hosted in order that it had its biggest opportunity to link in with as many people as possible. We worked with stakeholders, so patients themselves, and we were able to recruit patients through our education dissociative seizure group based here at the Queen Elizabeth, and also patients that had gone through similar intervention in Ayrshire. We worked with carers as well. Again, identifying carers through patients who had already attended some education work groups that we had run, and clinicians, and this incorporated obviously neurologists, neuropsychology, psychiatry, and we tried to do this across boards. So we integrated input from different boards from Aberdeen, Glasgow, Ayrshire and Lothian. We agreed the content and development of the pages, and we wanted to ensure that it was as interactive as possible. So there's written information, videos and cartoons in order to explain all of the information. We've had patient and carer feedback when we did a soft launch of the app, and we've made any relevant changes based on this feedback. And we launched the website for this in February of 2025. This is what our app looks like, and it is hosted in the NHS Scotland Right Decisions platform. And if we move to the next slide, then you see the range of tiles that comes up when you go into the app, and it just incorporates all of the information that I was telling you about there. As you get into each tile, there's a raft of information that sits behind there, going into how to use the app, moving through how the diagnosis is made, what it means, and really importantly, how do you begin to move forward with this condition and live well. Next slide, please. We wanted to ensure that we communicated the availability of the app as widely as possible. We developed outpatient flyers. We developed business cards that allowed the neurologist to just give this to the patient at the point of diagnosis for them to be able to access it. We did it through a QR code, again, to try and make it as straightforward as possible. And thankfully to Jon Stone, he also incorporated this into the Neurosymptoms website, which is hugely helpful, as that does tend to be the initial go-to site, certainly here in Scotland, for people to when they're given a functional diagnosis. And we've had a bit of media attention around it as well, and we've had some positive patient feedback. Next slide, please. So we launched in October after all of our soft launches. Our final launch was in October 2024. We have just over 9,000 views so far, with 2,600 active users. And when you look at the hierarchy of the most common pages that patients go into, the self-help and wellness toolbox is the most common one that patients use, then into dissociated seizures, the frequently asked questions, and then why do I have dissociated seizures? And all of the pages have been utilised at some point, but these are the top 4 that are most frequently looked at. Next slide, please. There is a number of contributors to this that supported Saif and I through this, from neurology, neurosurgery, psychiatry. Yet again, a huge thank you to our mental health librarian, who was absolutely integral, and obviously to our GGC management. Thank you.
Sharon, so thank you very much indeed. Very nice little, yeah, so if you're interested, I'd encourage you to go onto the Right Decision app and just have a little play around and have a look at that. Right, okay, so we're going to finish up in Aberdeen, and where better to finish up with Fiona Summers, who has spent many years working in this area, in this part of neuropsychology. So Fiona, welcome, and look forward to hearing you.
Helps if I put my mic off on. Can you see my slides? Just checking. Brilliant. Okay, so thank you for inviting me. I'm obviously going to have to be a little bit quick here to catch up, but I wanted to introduce you to the work we've been doing up in Grampian on developing an FND pathway. And we took a slightly different approach in Grampian because we also looked at other functional disorders. So this first came, just give me a moment to move forward. This originated really from elective care workshops that we ran in secondary care in 2018, where we asked a number of services across the board, where were there kind of pinch points in terms of delayed discharges, in terms of managing more complex patients. And out of all those workshops, including obviously neurology around FND, but also rheumatology, gynecology, cardiac, lots of other areas where patients that they would describe as functional. We then looked at, I had a number of trainees, both medical and psychology trainees, looking at the demographics around 3 exemplar groups. So we actually looked at FND, because that's obviously my baby, irritable bowel and fibromyalgia, just as exemplars of functional disorders. We also looked at healthcare utilisation of those 3 groups, which is a whole other talk in itself. We asked Robert Gordons to do a scoping review of pathways related, published pathways related to FND FND, irritable bowel, and fibromyalgia. We also included things like medically unexplained in that because in terms of published data, to be able to go back a little before kind of the FND was a more established diagnostic label. We also
Sharon, so Fiona, sorry, can I just interrupt? Are your slides advancing? Because we're stuck on the title slide. Is that intentional?
Oh, they should be advancing. Are they not with you?
No, we're stuck on the title slide just at the moment. Richard, are you able to advance? Oh, has Fiona just frozen?
Yes, it looks like it. Maybe why the slides are not moving through.
Yeah. Are you able to control it, or is it Fiona's end?
She's got she's the presenter, so she needs to move them through.
Okay. Yes, I think she's frozen. I think obviously the line to Aberdeen is slightly dicky just at the moment. We'll may just temporize and see if Fiona reappears. Otherwise, we might just take a couple of questions while we wait for Fiona to return. So as you've been seeing in the chat, some of the questions are being answered, and some interesting questions there. Michael, one question for yourself, actually. Someone was asking about what does a relapse plan look like? Is that a straightforward question to answer?
We have some set ones I can try and share in the chat afterwards, but it's mostly to do with trying to build an understanding with the patient of what their symptoms look like and what has helped them. So it's normally physio or OT will work through with us and be like, okay, so your legs aren't working, so what helps in the future? What has helped before? Okay, let's put that there so they are able to sort of manage their own care at home, so they can do basic physio things at home or basic psychological things at home rather than come back into hospital, and only consider hospital after they have tried all the basics. So it's quite a rough and ready thing. It's the same as our dissociative seizure management charts. We've got like a fairly woolly thing that we use, but it's more to do. It is a tool for starting a conversation, and you'll end up with quite a bespoke thing at the end of the discussion with the patient based on what has worked for them. And oftentimes what's really necessary is they know the stuff, they just need to be reminded they know it and be given in a really structured way and told that they can do it themselves, because people often think that they need the support, but often they don't.
Okay, thanks, Michael. And if you're able to put something in the chat, that would be very helpful. And John's just dropped something in there as well. And actually, John, I was going to come to you because there was a question earlier on as well about. It seems like FND is more common. Is there a real increase in incidence, possibly prevalence, or is it just that we're better at diagnosing it? The same argument with ASD and those other neurodivergent conditions, I guess.
Yeah, I don't think it is more common. I mean, there is a risk that if you raise awareness too much, people start to sort of notice very minor functional symptoms that perhaps shouldn't be called FND in the first place. But you go back to 1880s, Charcot, 10% of Charcot, the neurologist's outpatient clinic, was FND. Pretty, that's not that far away from where we are now. You look at figures from the mid-century. It's just been it was just totally ignored. It disappeared from textbooks. Neurologists lost interest, psychiatrists, they weren't sending patients to psychiatry, but I think the patients have always been there.
Lovely. Well, that's perfect timing because Fiona, I see, has just joined us again. Fiona, are you back online? Saw you pop into the chat in just a moment ago, but maybe not. Maybe not.
Oh, can you hear me?
Fiona, yes, we can. Yes, we can hear you. Can't see you, but hear you. Yeah, absolutely. Yeah.
Okay. Oh, you can't see me? No?
I can see you now. Oh, okay. No slides.
Let's try again. That's not very good when we don't have a great deal of time, but let's just see this time if we're gonna have any luck with. Are you seeing my slides?
Can see your slides, just need it in slide presenter view. Slide sort. Yeah, that's
I'm
it.
going to try and move forward. If I move forward, can you see my move forward?
Perfect. Working.
Okay.
Great. Thanks.
Phew. Right, where shall I pick up? And apologies for that. So we did the scoping review with Robert Gordon's University. Then we went on to Engage, Glasgow School of Art, looking at in-depth interview with 8 people with lived experience. We wanted, rather than questionnaires to a lot of people, we wanted to actually do something a bit more in depth to get the richness of it. All this is actually available if you go to Glasgow School of Art's website, the whole document about this. Obviously, it's a lot of piece of work and a lot of data. We also had 3 condition-specific workshops. I was very clear that I wanted GP, psychiatry, for FND, neurology, speech and language therapy, OTs, physios, social workers, psychologists. I wanted everyone represented at those workshops. So we had 1 on fibromyalgia, 1 on irritable bowel, and 1 on FND. And then we had 1 last overall functional disorders workshop that included a selection of people that had been in all of the workshops. So not surprisingly, I think for those, is that this is the kind of bottom line really from both patients and clinicians, was that they wanted psychologically informed care for all. They wanted building relationships with the individual. They wanted person-centered care. They wanted to feel heard, held, and empowered. So of course, what does that actually mean? When we drilled that down a little bit with patients and clinicians, what they were talking about was there was a need for a clinical and managerial lead for functional disorders to oversee any sort of implementation. And I think part of the issue within the NHS is functional disorders doesn't really fit anywhere. FND clearly fits within neurology, but actually if you've got fibromyalgia, you kind of fit with neurology, rheumatology. Irritable bowel kind of fits with gastro, but if you've got cardiac problems or gynae problems that don't really fit with either of those, you kind of bob around the system. And you're very familiar with this with FND, and the same happens in lots of areas. And interesting, all the feedback we've had back from those 3 exemplar areas has been very, very similar. So functional specialists to support patients, hear, hold, and empower. And tools to coordinate care through a portal. This is actually what patients ask for, some sort of portal that they can access what's happening to them. What did the OT just say? What did the physios say? What's the social worker saying? All these kind of things so that they can go and have one sheet. Almost, for some of us who are a little bit older, those kind of red books that patients used to get in the community that had all that was going on for them, but something that's a bit more digital. They wanted online resources for guided self-management. Guided was the important bit here, rather than just accessing it themselves without support. We felt there was a need to mapping current services, and what we have for FND and others is that we have a little bit of psychology doing something, we have a little bit of OT, a little bit of physio, but it doesn't seem particularly well coordinated, particularly in large geographical areas. And quite often there's pockets of really good work and then pockets where nothing's happening. So looking and scoping that. We also, there was a need for training packages online. I've said for years that I think having an online tourist FND kind of education package would be excellent, but actually on other functional disorders and other things too. And resourcing successful initiatives that lots of us have developed, including some of the ones that we've already talked about here, that they can be resourced to continue, but actually identifying what those are. If you see that link for the future health and wellbeing, that's the link to all the details about this. So what do we have in Grampian? In Grampian, what we've, things on the left-hand side have largely been resourced without any additional funding. And this is where I know for some of you who are going, but we don't have more funding, how can we make small changes? So these are the kind of things that we've introduced. We have 6 weekly FND multidisciplinary meetings that are very well attended. We've had them for many years. And to my surprise, I've been involved in lots of multidisciplinary team meetings on Teams, and this is very well attended. We have neuropsychology assessment for functional cognitive disorders and feedback for both inpatients and outpatients, but we don't do treatment. in-depth treatment around kind of trauma, but we do have an agreement now with adult mental health and primary care services, and they will see people with FND with a mental health diagnosis. So if they have a trauma background or significant anxiety or depression. We have yearly and sometimes more FND training. I've also done training up in Aberdeen for both Tayside and Highland around psychological therapies for FND for those working in primary care and adult mental health. We teach undergrads. We have our FND group within neuropsychology with some excellent outcome data. And we have FND leaflets, websites, and videos from our local clinicians talking about how they manage and support people with FND. What we need is clinical lead, we need managerial lead, we need FND practitioners, so it's great to hear what's happening in Forth Valley and Lothian. We need stronger links with GPs and secondary care. We need treatment options that they're sporadic and not well coordinated. And we need more support and education for patients and more support and education for clinicians. And my final slide is we have managed to get 1.5 million from NHS Grampian's charities, which we're delighted about. And you can see here, we've really gone for a gold standard. Again, this is not just FND, but we're advertising currently for 2 clinical leads, 1 day a week, 1 in secondary care, 1 in primary care. We are looking at 2 clinical coordinators practitioners, 2 clinical practitioners, so that's band 6s and 7s, as an assistant psychologist, 2 healthcare support workers. We need admin. We have costed in for service management, project management, and also data analyst, because I know lots of you clinicians out there will spend a lot of time doing this, and actually it's not a great use of resources. So we have data analysts in there, and we also have an engagement advisor to engage with our people with lived experience. And we also put some money in for physical supplies as well. So in terms of everyone else, we don't have any data for this because we hope this will kick off in about February time, and we will be collecting data and feedback. And obviously, we're looking at an exit strategy, and NHS Grampian we have contracts with Grampian charities to empower an exit strategy, I suppose is what we can say. And that's it. Thank you very much.
Fiona, thanks very much, and well recovered. Thank you very much indeed. It's difficult when things give up on you, but that was really helpful. Thank you very much. Now, in fact, we took a couple of questions whilst you were offline, so we're doing fine with time. In fact, now there have been some answers in the chat, and just to remind you that the various resources and links will be sent out, I'm reliably informed, subsequently, so don't worry too much about that. I wanted to actually, the very first question maybe aligns with that last question by Lars, and that's the issue about the first question was this perception that many people with FND do not seem to be aware of their diagnosis and don't recall being told that they have FND. It might be on their records, but they have no recollection of being told that. And then Lars was making the point about people being believed. And there's a sort of link between those two. So Jon, can I come back to you about that one in terms of both those points?
Yeah, I mean, it is an issue. I think when you're presenting, someone's got multiple physical and often mental health symptoms, they're feeling bewildered. I think people often expect patients to be sort of grateful or understand things even though they're giving them a 3-letter acronym they've never heard of. And that's particularly the case, I would say, if they don't offer follow-up. I think it's really essential for whoever's giving the diagnosis to see that person again, because if you discharge the patient, doesn't matter what you say, you're sending a message to them to say, I'm not very interested in this problem. So you could say, I believe you, and these sort of things. But I think actions speak louder than words here in terms of, here's your condition, here's some information, but I'm going to see you again, and here's some ways that we're going to help you understand it. So I think people underestimate how long it does take to properly get these ideas across and make people feel understood. Often takes several sessions, I think.
Yeah, yeah, thank that. Yeah, no, thank that. That certainly rings very true from my experience, and I know I'm guilty of exactly that, that some of those problems. Um, right, I'm just having a little look through our various questions. There were questions about children's services, which I think have been adequately addressed, but we're strictly speaking about adult services here. I think there was that interesting question about providing rehabilitation equipment and at what stage you can make that decision. Jon, I know that you partly answered that, but I because you made the point, there's this balancing act between not sort of providing the wheelchair straight away and sort of, if you like, almost encouraging disability that's maybe not necessarily appropriate, but equally sort of not denying them services. Do you want to expand a little bit on that important question? Because I can see how therapists can find that quite difficult.
Sure. I mean, I don't want to hog the mic, so others may want to come in, but I think that yeah, there isn't a black and white answer to this. I think perhaps some services started off with a very firm view, or people with FND shouldn't have aids and equipment, when I just don't think that's the case. Particularly, we have to recognise our treatments are not that good, actually, and many patients do not get better with the treatments. We have to be honest about that. And if you've got severe disability, then equipment and aids is going to help you be more independent. At the same time, introduced too early, they can be an obstacle to improvement. But if someone's very disabled and can't get out of bed, you're going to need equipment and aids as part of that rehab process to get them better. So I think it's about having a more nuanced view of rather than a sort of black and white one. Yes, I don't know if anyone else wants to comment on that.
Yeah, but Pete, I mean, anything from your perspective in NHS Forth Valley that you would add to that? Because I think it is a really difficult area, isn't it?
Yeah, of course. And I saw that Emma Forbes from Forth Valley had just raised her hand as well. Emma's one of our leads in the neuro rehab team on this very topic. I find it's probably one of the most difficult bits about being the neurologist lead for FND, is that often what I find is that my physiotherapists are determined to just keep going and going and going and going, despite the fact that we might not be seeing any improvements. And part of my role, I think, in those MDTs is to be able to say, I think we've demonstrated a non-response, and now move into a supportive management phase. So yes, that is a difficult phase to be in, and I think there's a lot of support that's needed for the staff as part of the wider MDT. But I agree entirely with Jon that it's not a black and white issue. There are people for whom you will see improvements and they respond quite well to treatment, but many who don't. And I think that's probably part of the neurologist's role, is to be able to recognise that and then make recommendations that are sensible for maximum independence. Yes.
Pete, thanks very much indeed. Well, look, I hope we've tried to address many of the questions. I mean, a huge topic and not much time, so appreciating that we've been sort of scratching at the surface, but we've had several fantastic presentations, and I hope that's been of value. I've been looking at the retention level. We're at 271, which is pretty impressive in terms of retention for a meeting that hit 300, just demonstrating the interest in this area. Just to remind you, there is that evaluation QR code. As always, people very interested in the evaluation of the meeting. So please, if you can spend a few minutes to do that. And as I say, this is being recorded. So if there are bits you missed, you can watch it again and have a look at the chat. And also we'll send out the various links. But look, it just remains for me to thank all of our experts for their presentation. Thank all of you for attending. As I say, I've never been in a meeting this size. So thank you very much indeed. I hope you've not missed the budget too much, although we all know what's coming. So anyway, on with our Wednesdays. Great to see you all. Cheerio. Bye-bye.